Starting with Chapter 11, we will begin reviewing body system specific chapters and disease processes. So Chapter 11 is the endocrine, metabolic, and nutritional disorders and the immune system disorders. Diabetes is a chronic disorder of impaired carbohydrate, protein, and fat metabolism. DM can be caused by either an absolute decrease in the amount of insulin secreted by the pancreas, known as type 1, or a reduction in the biological effectiveness of the insulin secreted, known as type 2. Other conditions include the term diabetes, such as bronze diabetes and diabetes insipidus. But a diagnosis of diabetes without further clarification or qualification should be interpreted as diabetes mellitus. Type 2 diabetes is more prevalent than any other type. When coding diabetes, in order for the code to be valid, it must consist of 5 digits. The 4th digit identifies the presence of any associated complications, and the 5th digit subclassification includes both the type of diabetes and whether or not it is considered to be out of control. There are 3 types of diabetes. Type 1, also known and described as ketosis-prone, juvenile type, juvenile onset, or juvenile diabetes. Type 1 diabetes, in type 1 diabetes, the body does not produce insulin at all, or there's an absolute decrease in the production. These patients require regular insulin injections to sustain life and experience significant health problems if they do not follow a proper diet or medication plan. Type 2 is sometimes described as ketosis resistant. Patients with type 2 diabetes do produce insulin, but it is either in an insufficient quantity or the body is unable to utilize it effectively. These patients usually do not require insulin and can ordinarily manage their diabetes with oral hypoglycemics, diet, and exercise. Some patients may require insulin therapy to control their persistent hyperglycemia. In this situation, an additional code V58.67 is assigned. When the provider does not document the type of diabetes, the type 2 is considered the default code. Secondary diabetes is usually resulting from therapies such as surgical removal of pancreas, pancreatectomy, a malignant neoplasm of the pancreas, an infection, or the use of certain medications. Secondary diabetes is coded as follows. If drug-induced, chemically induced, due to post-carcinoma state of the pancreas, or due to an infection, you would code to category 249, secondary diabetes mellitus. It is important to know you would never assign a code from category 250 when coding secondary diabetes. To give you some examples of how these codes are done for secondary, let's consider an example of drug-induced secondary diabetes mellitus. So the example is steroid-induced diabetes mellitus due to a prolonged use of corticosteroids for an unrelated condition. This is coded to code 249.00, secondary diabetes without mention of complication, not stated as uncontrolled or unspecified, and an E code, E932.0, adverse effect of a therapeutic use of an adrenal corticosteroid. And another example is secondary diabetes due to pancreatectomy. In this, you would assign a code 251.3 for post-surgical hyperinsulinemia, a code from subcategory 249, and either a code of V88.11 or V88.12, showing either an acquired total or acquired partial absence of the pancreas. Out of control or uncontrolled are synonymous in this context. Poorly controlled or poor controlled are vague terms and do not necessarily indicate uncontrolled blood glucose levels. You would use the code or code the code uncontrolled only when the physician identifies it. Uncontrolled diabetes is a nonspecific term indicating that the patient's blood sugar level is not kept within the acceptable levels by his or her current treatment regimen. Causes of uncontrolled diabetes may be noncompliance, insulin resistance, dietary indiscretion, or intercurrent illnesses. If the provider states borderline diabetes without any further confirmation of the disease, then it is coded to code 790.2, abnormal glucose. When a type 2 diabetic patient or a patient with secondary diabetes routinely uses insulin, assign code V58.67 for long-term or current use of insulin as an additional code. V58.67 should not be used if insulin is given temporarily to bring the patient's blood sugar under control during the encounter. Some type 1 diabetic patients require the use of an insulin pump to receive insulin therapy. Failure or malfunction of the pump may result in underdosing or overdosing of insulin. These are considered mechanical complications and are assigned code 996.57, mechanical complication due to an insulin pump. When there is an overdose of insulin as a result of the pump malfunction, code 962.3, poisoning by insulins and other anti-diabetic agents, is assigned as an additional code. Our coding guidelines tell us to assign as many codes from category 250 as necessary to identify all associated diabetic complications the patient may have. There is no limit. Common complications of diabetes include chronic kidney disease, neuropathy, and retinopathy. Patients with diabetes are prone to kidney complications such as nephritis, nephrosis, or other chronic kidney disease. Diabetic nephropathy is coded to 249.4 or 250.4 with an additional code of 583.81, nephritis and nephropathy, not specified as acute or chronic. Or is 249.4 or 245.4 and code 582.2 when the renal condition is described as chronic glomerulonephritis. Diabetes with nephrosis or nephrotic syndrome is coded to 249.4 or 250.4 and code 581.81, nephrotic syndrome and diseases classified elsewhere. When the condition has progressed to chronic kidney disease, the diagnosis is somewhat stated in a way that it appears to require 3 codes, one for diabetes, one for the interim manifestation, 581.81, and one for the final and current problem, 585, for chronic kidney disease. It is not necessary to code the intermediate condition, but all 3 codes may be assigned if the hospital prefers. It is common for most facilities to only assign the diabetes code with a chronic kidney disease code. Patients who have both diabetes and hypertension may develop chronic kidney disease as a result. In these instances, 3 codes are needed. A code for the diabetes with renal manifestations, either 249.4 or 250.4 with the appropriate 5th digit. A second code from the category 403 or 404 to show the hypertension, with a 5th digit of zero, with the chronic kidney disease stage 1 through 4 or unspecified, or a 5th digit of 1 for chronic kidney disease stage 5 or end-stage renal disease. And then a 3rd code is needed from category 585 to indicate the specific stage of the chronic kidney disease. No other manifestation code is assigned. Retinopathy is a common complication of diabetes. Any disease of the retina said to be due to diabetes requires a code of either 249.5 or 250.5 and an additional code for the retinal complication. Non-proliferative diabetic retinopathy may be specified as mild, 362.04, moderate, 0.05, or severe, 0.06. Assign code 362.03 when the degree of severity of the diabetic retinopathy is not specified. Diabetic macular edema is only present with diabetic retinopathy. Therefore, if the documentation refers to diabetic macular edema, code 362.07 must be used with the appropriate code for diabetic retinopathy from 362.01 through 362.06. Senile cataracts develop more frequently in patients with diabetes, but they are not true diabetic cataracts and are not classified as ocular manifestations of the disease. A code from subcategory 336.1 for senile cataract and a code 249 from secondary diabetes or 250 from diabetes should be assigned for the senile cataracts in a diabetic patient. The sequencing of such would depend on the circumstances of the admission. Diabetic cataracts, known as snowflake cataracts or true diabetic cataract, is extremely rare. Assign codes for diabetic cataract only when the physician specifically describes the condition as such. Neuropathy is another chronic manifestation of diabetes. Patient conditions can include peripheral, cranial, and autonomic neuropathy. Peripheral neuropathy codes 249.6 or 250.6 and code 357.2 for polyneuropathy and diabetes. Autoneuropathy codes 249.6 or 250.6 with an additional code of 337.1 peripheral autonomic neuropathy and diseases classified elsewhere. Do not use the code for autonomic neuropathy unless the diagnosis is stated as such by the physician. If the neurological condition is specified, assign the code for the more specific manifestations. Words such as with or with mention of, associated with, or in indicate that both elements in the title must be present in the diagnostic or procedural statement. Although these terms do not necessarily indicate a cause or effect relationship, they occur together much of the time, and the classification system indicates this relationship. Acute metabolic complications include ketoacidosis, hyperosmolality with or without associated coma, and other comas. Type 2 diabetes seldom develops ketoacidosis. Classify as type 1 diabetes uncontrolled. Diabetic ketoacidosis, by definition, is uncontrolled, and 250.13 is the default unless the physician has specifically identified it as type 2 diabetes. Diabetes with hyperosmolality generally occurs with patients with type 2 diabetes. Coma may or may not be present. Diabetes with other coma, code 249.3 or 250.3, includes patients with ketoacidosis who have progressed to a comatose state. This code includes a hypoglycemic coma in a patient with diabetes and insulin coma, not otherwise specified. Although arteriosclerosis occurs early and more extensively in diabetic patients, coronary artery disease, cardiomyopathy, and cerebrovascular disease are not complications of diabetes and are not included in the code 249.7 or 250.7. These codes would be coded separately unless the physician has indicated a causal relationship. Ulcers are also common in diabetic patients and may result from either diabetic neuropathy, code 249.6 or 250.6, or from diabetic peripheral vascular disease, going to code 249.7 or 250.7. Just because a patient is diabetic and has an ulcer does not necessarily mean the ulcer is diabetic. You must query the provider when they do not specify diabetic ulcer. Diabetes inevitably complicates the pregnant state, is aggravated by the pregnancy, or is the main reason for obstetrical care. You would also assign the code V58.67 long-term care use of insulin if the diabetes is routinely treated with insulin. Gestational diabetes refers to an abnormal glucose tolerance during pregnancy in previously non-diabetic women. Gestational diabetes is not true diabetes mellitus. Gestational diabetes is thought to be a metabolic or hormonal change that occurs during pregnancy and usually resolves during the postpartum period. You would never use code 648.0 for diabetes complicating pregnancy and a code 648.8 for abnormal glucose tolerance complicating a pregnancy on the same record. So never code either full diabetes in a diabetic woman who happens to be pregnant, or the gestational diabetes, the abnormal glucose tolerance in a non-diabetic. So it all depends on if that mother is a diabetic to begin with or a non-diabetic to begin with. When a normal infant is born to a diabetic mother and the infant presents no manifestations of a diabetic mother syndrome, you would assign code V30.00 for single live born in the hospital delivered without mention of a C-section as principal, and an additional code of V18.0 to show family history of a certain other specified conditions. Or, if the infant is being observed for a suspected condition related to the diabetes and there is no definitive finding, then you would code V29.3, observation and evaluation of newborns for a suspected condition not found. Newborns with diabetic mothers sometimes experience either transient decrease in blood sugar, 775.0, or transient hyperglycemia, 775.1. The fact that the mother has diabetes in itself does not warrant the assignment of one of these two codes for the newborn. When the lab reports seem to indicate either condition, it is appropriate for you to check with the attending physician. Hypoglycemic and insulin reactions are very common. If a diabetic patient experiences hypoglycemia, it is coded based on whether or not the patient has a coma or no mention of a coma. If the patient has a coma, then the code is assigned based on the type of diabetes, either 249.3 for secondary or 250.3 for diabetes with other coma. If the patient does not have a coma, then the code assignment is 249.8 or 250.8. Hypoglycemia due to a drug used as prescribed requires an additional E code to indicate the responsible drug. Hypoglycemic coma or shock resulting from the incorrect use of insulin or anti-diabetic agent is coded to a poisoning, 962.3 plus E858.0. Nutritional disorders include deficiencies of specific vitamins and minerals and are classified to categories 260 to 269, except for deficiency anemias, which are classified to 280 to 281.9. Obesity codes can be assigned as a principal diagnosis when the underlying cause has not been identified, or they can be assigned as a secondary diagnosis. Obesity due to a specified cause such as a thyroid disorder, codes 240 to 246, is coded to the underlying condition. These codes are assigned only on the basis of physician diagnostic statement. It's important to remember that obesity codes require an additional code for the body mass index, if known, going to code V85.0 to V85.54. The BMI code assignment should be based on the medical record documentation, which may be found in notes of other clinicians involved in the care, such as the dietitian or the nurse. This is an exception to the guideline that requires that code assignment be based on the documentation by the physician. While BMI may be reported on the basis of another clinician's documentation, the codes for overweight and obesity should be based on the provider's documentation. Obesity can also lead to other conditions such as obesity hypoventilation syndrome, OHS, which is also known as Pickwickian syndrome. Pickwickian syndrome is a sleep disorder where it causes the person to stop breathing for short periods of time while sleeping. The condition may be related to both obesity and neurological conditions. The effects of hemochromatosis are: iron can build up 4 times the normal amount. Toxic levels may affect the pancreas, liver, heart, pituitary, thyroid, and joints when left untreated. Organs may fail, causing diabetes, arthritis, cirrhosis, hypothyroidism, myocardial infarction, and neurodegenerative diseases. Hemochromatosis is also known as bronzed diabetes because of the color of the skin due to excessive iron. There are 2 common types of fluid overloads. The first is when the fluid overload is an excessive accumulation of fluid in the body with no known cause. When fluid overload is a component of congestive heart failure, it is not coded separately. The second condition is transfusion-associated circulatory overload, also TACO. This occurs when transfusion volume exceeds the cardiovascular capacity. The symptoms include dyspnea, hypoxemia, an elevated venous pressure, and pulmonary edema. Cystic fibrosis is a disease disorder of the exocrine glands that causes accumulation of thick, tenacious mucus. It is the primary cause of pancreatic deficiency and chronic malabsorption in children. Symptoms primarily affect the digestive and the respiratory systems. Code assignment is based on the site of the manifestation. If a patient is admitted due to complication of cystic fibrosis with pulmonary involvement, such as an acute bronchitis, you would code the complication as the principal diagnosis or first listed condition, followed by the cystic fibrosis code. Tumor lysis syndrome is a group of serious, potentially life-threatening metabolic disturbances, which can develop spontaneously following radiation therapy or corticosteroid therapy, or following the administration of anti-cancer drugs, and it is often associated with leukemias and lymphomas. This condition can also be seen in hematological malignancies and in solid tumors.